Well, I want to thank Corey for the invitation. He had a little something to help with this title, so I think I thought it was a very unique and nice title to an appropriate one probably for lung cancer, especially cetuximab. I did move just 1 minute to Charlotte in June, and so there is a new cancer institute that was formed. Derek Ragavan, formerly of the Cleveland Clinic, is the president of this institute. It is in the Carolinas healthcare system, which is the second largest nonprofit system in the country, 40 hospitals over 2 states. So they have decided to create an institute which will be a cancer service line throughout their system. And so the Levine Cancer Institute right now has 15 charter sites throughout the Carolinas healthcare system in North and South Carolina. 12 of those sites are under a central IRB. We hire all the research folks, so it is meant to be a real integrated community network. And part of the challenge is to take the research and the comprehensive medicine to the community. So we actually hired the 3 major private groups in Charlotte. So they're all faculty members now, paid under us. There's no incentivization for chemotherapy, just putting patients on trials and seeing patients. So it's a unique model that's sort of being created where we're at. And ask me next year to see how it's going, because I've only been there 3 months. So, cetuximab is really a nice drug. It does great things in head and neck cancer with radiation, with chemotherapy. It does some nice things in colorectal cancer. You have a biomarker there, KRAS, so some people try to make the association there. The question mark is, what are we doing in lung cancer with it? And hopefully by the end of this, you'll have an idea, or less of an idea, of which it is. So right now, EGFR approved therapies, and these are FDA approvals. We don't have any for a non-small cell in front line. Down here at the bottom, I included the EGFR mutation. We do have a afatinib, which is pending, and we'll see if that gets approved. They did show phase 3 data in EGFR mutant selected population, and clinically, erlotinib is used in this, and it's on the major guidelines. But again, there's no official indication for the drug with this. We certainly have erlotinib in maintenance and erlotinib in second line, but that's about it. So it seems kind of thin that, in fact, a field like EGFR, which has just been huge, and Dr. Ramalingam just showed you a VEGF field with tons and tons of drugs in it, there's not a lot here. So it's very interesting to see how that's going. So starting with SWOG 342, and I'll have to say that Fred Hirsch drove a lot of the biomarkers here, and none of you like EGFR fish, so just bear with me as I get through a lot of that. But this was the SWOG study that looked at concurrent versus sequential cetuximab. And in fact, continuing cetuximab versus sequencing it, and a lot of this trial changed because of the negative data with TKIs. When they showed that you mixed in TKIs with chemotherapy, you almost had this antagonistic effect, and so the fear is that by putting them together, you might do worse, and so that's why they separated this out for that design. I can tell you I knew exactly how this trial was designed, and it showed absolutely no difference either way. So that either meant that it was good to continue cetuximab and have this sort of continuation maintenance, or it meant that cetuximab had absolutely no effect, and you were going to get the same numbers either way. There's always 2 ways you can interpret trials that way. And then looking at FISH, which again Dr. Hirsch has sort of led this whole field in and really is passionate in his belief in this as a biomarker, showed that if you had higher levels, 5 or 6 is how he scored it in the FISH score group, then PFS and overall survival were better. And down here in the 45 patients with 29 events, 15-month overall survival. So that was the signal that was used in one of these 2 studies. I'll move on to FLEX, and we'll come back to the SWOG study later. So FLEX was a large phase 3 study. Many of you know about this. It was published in Lancet, presented by Dr. Pirker. Over 1,100 patients involved. These were just randomized. These were all comers. This is not a selected population. That's the first reference to select. And you'll see that combining with cisvinorelbine with cetuximab or not, primary endpoint was overall survival. We used to get really excited when we had primary endpoint studies of survival, overall survival, that were positive, and the enthusiasm for this study was less than that, at least in North America. Part of it was cisvinorelbine as the backbone. Not many people liked that regimen. The other was the fact that it was cetuximab, and some people just didn't like the data so much, and this was the data. So you had a difference here of of 11.4 versus 10.3. Now, this is the wild type, KRAS wild type population, but the numbers are very similar. The overall difference was less than 2 months, and for some reason, we are hung up on this 2-month overall survival sort of median. And the problem with that is that as we start pushing survivals out to 15, 20 months, and we'll get there, 2 months is not the same as going from 8 to 10 months. So they looked at a bunch of different factors, looking at the KRAS wild type, KRAS mutant, the fishes, all these other things, and you can see nothing really has panned out that well other than a response rate here. So not a lot of conclusive data could be made from FLEX as far as whether a biomarker helped power any of this stuff. At the same time FLEX was being done, an earlier trial done by Tom Lynch was BMS 099. And the difference here was that this was an open label study. This was not a placebo-controlled study. And it looked at using carboplatin with either docetaxel or paclitaxel with the addition of cetuximab. This kind of gave us the first hint that maybe we were going to have some complicated aspects, especially in FLEX and cetuximab. You can see here the PFS, which was the primary endpoint, was really no different between the two. And whether it was investigator looked at or not, you saw response rate differences, you saw some trends in survival, but you didn't see any difference in PFS. And this was consistent in both of these studies. And so the overall survival, again, if you've got to look really hard to find a space, you're not finding the space well enough. And anytime you have 2 decimal points, out with survival or weeks, those are all bad things. They also looked at biomarker analyses as well, looking at EGFR mutation, KRAS mutation, IHC, and FISH, and they saw no real significant treatment-specific correlations between these factors. What you'll see on NCCN is that you'll see a category 2B for frontline, but category 1 for maintenance. So again, we even get mixed signals from our national organizations on how this should be done. And so I'm not sure where people are using cetuximab right now, frankly, because it was not approved in Europe. It's not approved here. But there is anecdotal usage, and everyone's comfortable using this drug, obviously, unless you're now where I've located, which is in the North Carolina, South Carolina, or Tennessee belt, where you'll have some issues with hypersensitivity. So let me move to SELECT. So reference number 2 to SELECT. So SELECT was meant to be one of the large phase 3 studies that will help get cetuximab approved. This was a second-line study of docetaxel or Pemetrexed with or without cetuximab in second-line patients, recurrent or metastatic. It is based on a phase 2 study that showed a response rate of 28%. And then in a randomized study, again, differences in response were seen. So generally, response follows and progression-free survival follows afterwards. If you're seeing responses, you get excited about that. Second line, 28%, pretty good, especially when you expect about 8% with those folks. So Pemetrexed became approved during the development of this study, and so was later added in. This was a complicated study in that you basically had physician's choice, either Pemetrexed or docetaxel, and then you were randomized to either receive the drug or drug with cetuximab or drug alone. The primary endpoint was built around Pemetrexed. You had to choose one or the other, and that's what Eli Lilly obviously chose. If those are reasons I have to explain to you, then we'll have to have a second course afterwards to decide that. So again, it was the primary endpoint was PFS with weekly cetuximab in combination with Pemetrexed versus Pemetrexed alone. They did look at the other arms as well. The phase 2 data, mind you, was with docetaxel, so that was where the promising response rate came from. So there were, again, further debates about this. These were the assumptions, 605 patients in the Pemetrexed cetuximab arm to look at a 2-sided test, 5% significance level. I won't go through these in a lot of detail, just to show you that it was a pretty well-balanced study looking just at the Pemetrexed groups. That's why you see 605 patients here, comparable demographics and disease characteristics, again, all pretty comparable. There wasn't a lot of difference. We did actually review the path reports for all of these different folks, and non-squamous was a big bucket, which included adenocarcinoma and others that didn't specify squamous. So this is the exciting data that I can share with you today, and you can see the Primary endpoint, or one of the endpoints here, progression-free survival, no difference. 2.89, 2.76. It's not the type of curve you want to be seeing here. And overall survival, even more compelling to show you the non-difference. So just hovering exactly above where you might be. Some people might be artistically inclined to say that there was actually a higher survival with Pemetrexed alone versus Pemetrexed plus Cetuximab. You can see how these curves go. They kind of weave in and out from each other. Response rates, there was a higher response rate, but overall pretty poor response rate in general. So again, highlighting all of our pessimisms in second-line lung, especially in an ironically named SELECT study, which was a clearly unselected study as far as a biomarker. So when you look at all the other factors, PFS, an OS with histology, again, and subgroups, you don't see a lot that jumps out at you. I could have inserted a few jokes like Dr. Ramalingam here just to spice it up a little bit, but this data, we just got to get through it and you have to see it. It's good to reinforce those CME learning objectives that we have at the end here. So when you also look at toxicity, people know how to manage this drug. You don't see very many differences here. And it was pretty well controlled otherwise. You will see acne and rash with Cetuximab. And so when you look at all the grade 4/5s, again, pretty easily tolerated. There was 1.7% cardiac events here, but otherwise really no issues. So the addition of Cetuximab to Pemetrexed, I don't need to say it, didn't show anything to benefit. The docetaxel group looked correspondingly sad, just as this one did. And so there were analysis looked at EGFR staining and others, so those who picked IHC, probably the best one to choose, but there is no marker right now that you should check for Cetuximab in lung cancer. Now, the last little tidbit is this H-score analysis. There was a subset of folks that were looked at in the FLEX study that showed H-score was predictive. We have run those tests. Is this being recorded? It probably is, right? No? Is it? We haven't presented that data publicly yet. All right. But you will know very soon. How's that? No press releases planned. The SWOG 0536 study was another study that looked at Cetuximab, and this was a study that I chaired through SWOG. It was a study in which we looked at a single arm, 110 patients of safety. Because it was a 4-drug regimen, Cetuximab, bevacizumab, carboplatin, paclitaxel. We wanted to see the severity of hemorrhagic toxicities in these patients. Again, evaluate progression-free survival, overall survival, et cetera. So this was the design. Again, it was using the standard doses of carboplatin and paclitaxel with Cetuximab and bevacizumab. There was some criticism of this study as we were running it because the colon data that combined EGF and VEGF inhibition, those studies did not pan out. However, we said this is lung cancer, not colon cancer. There are some differences that many of us thought existed, and so we proceeded on. You then did get Cetuximab and bevacizumab maintenance. So I would also argue that this is not the most expensive regimen we could put together in lung cancer. We could have easily substituted some of these chemotherapies for much more expensive chemotherapies, but we tried to keep some cost containment here. So what we did see actually was the highest median survival ever reported in a SWOG lung study, which was 15 months. We saw response rates over 50%, and we did not see the excessive toxicity between the two drugs. So the decision based on this and the exciting data was that we would move forward with a large randomized phase 3. And so what the SWOG 0342 built into with SWOG 0536 is SWOG 0819. This is an intergroup study. Many groups are participating, and it built on, again, the two phase 2 studies that were done through SWOG. This was to look at patients with either carboplatin, paclitaxel, bevacizumab, followed by bevacizumab maintenance as the ECOG control arm. And then you can also look at the 4-drug regimen and then get doublet. And then if you also have squamous, you actually are tested with carboplatin, paclitaxel, and Cetuximab here. So it's meant for all comers to come in. Depends on your histology. You are looked at. They are wanting 618 FISH-positive patients and 1,500 plus overall patients, because it will look at a co-primary endpoint of those patients in the FISH-positive setting, as well as overall survival. So this is probably the last stand for cetuximab. This study is really one of the few out there. There are radiation studies that are being done through RTOG, and we know that cetuximab has great radiosensitivity properties, but as far as in the treatment setting for metastatic non-small cell, this is it. Probably going to take a couple more years. The enrollment has been brisk, about 30 patients a month, so we've been on pace. So that is, the conclusions are is that it's unlikely to be approved on frontline unless this cooperative group study gets positive. I don't think I need to highlight how negative the second-line SELECT study was, and it's about as negative as it can be. And it really is going to see how the 0819 study does. You can hold your breath for H-score. I wouldn't, frankly. But unless something comes out, it's really quite unfortunate that a nice active drug like cetuximab, a drug that is safe for folks, that has been tested in multiple places, we have failed to identify a biomarker that would fit a patient population into this drug. And that's the tragedy of the whole thing, is because many of us have seen this drug just been studied for years and seen promising activity. But so the onus is on us now as clinical researchers and folks in the community who are conducting research or participating, is to really, we can't let drugs like this just come and go through lung cancer. We don't have enough of them. And so it's really quite sad. I think this is probably the end for cetuximab. So that's what the unfortunate part is. Thank you.